Excellent. Well, thank you everyone for the opportunity to be here today. My name is Victor Wu, and it really is an honor to be in a room with so many great leaders and thinkers around health literacy. I also take it as a great badge of honor to be the person standing between you and lunch for later this afternoon. So I realize that will be adds to my challenge, but luckily I'm talking about health literacy with a roundtable on health literacy, so it's really like preaching to the choir here. So I wanted to spend a few minutes this morning talking about health literacy and the Affordable Care Act with a specific focus on vulnerable populations. Obviously, we know that the intersection between health literacy and health insurance literacy is becoming a growing and apparent need in the country. And I'd like to spend a few minutes talking about the different strategies that we're seeing on the ground of individuals and groups that are involved in health insurance enrollment and how they're helping to align the skills and abilities with the demands and complexities. I have an opportunity to be working on a project and looking at some of these lessons that are being learned from the ground, and would like to share some of those insights with you today. As you know, the ACA has really transformed access to health insurance in this country. It comes as no surprise. It's been in the paper everywhere all the time for the last year and a half, the highlights and the lowlights of insurance enrollment. And there's been a heavy focus on trying to get individuals to get coverage for their first time. Many individuals who've been locked out of the marketplace, may not have been able to afford it for whatever reason, are having access and opportunities to have health insurance in new ways. A New England Journal of Medicine article earlier this year, a few months ago after open enrollment, noted that there was a net of about 10.3 million previously uninsured Americans who are now insured. And the uninsurance rate in America is the lowest it's been. We know about 8.5 million new individuals access and purchase health insurance through the federal and state exchanges, and another 5 million or so additional new enrollees in Medicaid and CHIP. So we realize that ACA has really, on many different fronts, but particularly in the health insurance access front, has changed the way that our country now thinks about health insurance access. With that, you know, the types of folks that are accessing health insurance through the marketplace, as it comes as no surprise, also represent oftentimes very vulnerable populations. Prior to the opening of the marketplaces, while non-Hispanic whites were still the total number, highest number in the country, the percentage for minority populations, African American, Asian American, Pacific Islanders, Hispanic, were disproportionately represented in those that are uninsured. Again, facts and figures that many of you have heard already at this point. But looking after the first period, for the first open enrollment period, nearly 2 out of 3 individuals who bought insurance through the marketplace said they had difficulty understanding terms like provider network, deductible, premium. I still have a hard time understanding those as well myself. And 6 out of 10 were previously uninsured. And lastly, 8 out of 10 were eligible for tax credits. These are just some statistics around those who were able to purchase health insurance, that were able to navigate the system and able to complete and successfully enroll in a health insurance plan. Again, we're seeing that there's opportunities, but also for great improvement in health insurance access, but also opportunities for widening of disparities amongst those who are now accessing health insurance for the first time, both in terms of lower income levels, lower education levels, disparate populations, vulnerable populations. So one of the opportunities I've had is to work with some members of the Roundtable and looking at some of the lessons learned from the front lines. We've been interviewing organizations across the country, local, state, national organizations who have been working directly with those, whether they are funders, whether they're direct community service agencies or community advocacy groups, but those who have had direct contact with assisters, navigators, certified application counselors, whatever other term you want to throw out there for them, the milieu of those working directly on the front lines with those enrolling. And they've been focusing, we were specifically focusing on successful strategies for hard to reach or vulnerable populations as the organizations themselves would define it. And these oftentimes included, but not limited to, those with limited English proficiency, Hispanic, AAPI, African American immigrant populations, LGBT populations, homeless and runaway youth, low-income populations. These were what the organizations on the front ground were identifying as some of their harder to reach populations, as well as looking across. There's been a lot written about this now. Luckily, the field will continue to grow, and a lot of qualitative and quantitative research will hopefully come as the years progress now that we've passed the first open enrollment. But how exactly is it that we can engage some of these these low health literacy populations or vulnerable populations and help them navigate the demands and complexities of the system? Well, some of the quotes and comments that we'd heard, I wanted to add some color before moving into the direct strategies. But, you know, for example, the LGBT community responded best to assisters who themselves identified as LGBT. They knew they could trust them. Assisters had been through what they are going through now. Similarly, we'd heard often that a head female in the household was a health decision maker. That was not our experience in our AAPI community. lessons that on the ground may or may not have played out the way that we would have thought from a more policy or national level. There's no substitute for an in-person encounter with someone who spoke the language. Another group said, data was key. Without it, we wouldn't have known where to go. We found that even after signing up for insurance, consumers would contact us several times afterwards on how to use it, a key comment that came up multiple times throughout different organizations. And lastly, another interesting quote that I found. Our community, which included several uninsured and Hispanic individuals, needed multiple touches before being ready to sign up for insurance. So health insurance enrollment, just to kind of take one step back and think about how have we thought about this as a nation and local levels, again, hearing from experiences of those that are doing this. We've kind of broadly lumped everything into outreach and enrollment as a whole. But really, when we think about some of the lessons that we're learning from those that are doing it on the ground, there are really three major buckets of health insurance. There's outreach and education, there's sign up, and there's use. All three of these, in many ways, are interconnected, they're integrated, but yet they're distinct processes along the way that an individual, a consumer, a patient needs to become ready to move from one step to the other. Those who are in outreach need to become ready to think about signing up. Those who have actually signed up then need to become ready to know how to use their health insurance and to access a provider, to find a provider in the network, and then actually begin using health services that will help improve their health, a lot of the topics that we've heard about today. And underlying all three of these buckets, there's really the language and the culture, the tone and the attitude with which individuals intersect with the health insurance system, whether it's through the enrollment in the marketplace or a provider level or navigators and assisters. All of these four pieces also form some of the underlying inputs and activities and drive a lot of the way that we communicate about how to navigate and go through what we broadly have called health insurance enrollment. Again, there's outreach, there's sign up, and there's use. Above these, we know that there's inputs and activities. And these is what we focused on a lot. There's major organizations, large national organizations like Enroll America. There's local organizations who have 2 or 3 in the office staff that are really working on these different inputs and activities. Whether the facts of what health insurance is about, how to get it, whether it's the people that you come in contact with, the places, the influences, the conversations that you're having, whether at the kitchen table or in an office setting or at a hospital system. And there's also the activities. There's the plan of attack. There's the workers. There's the materials. There's the processes. All these feed into the overall buckets of health insurance enrollment. And how do we navigate the system? How do we align the skills and abilities with the demands and complexities of each of these individual processes that overall together form a piece of the entire health insurance access pie? And lastly, after we've completed the first year, underneath the bedrock of all this that will help us improve as individuals and organizations doing this activity is really to begin to measure and evaluate in a way that's helpful, meaningful, and actionable. So really taking this framework has really been one of the first things that we'd heard on the ground, and how does this inform the way that we think about strategies to navigate between each of these buckets. And I wanted to share a few high-level strategies that we've heard that were successful and some anecdotes that go along with it, just as a way to show some of the way that individuals on the ground are very practically tackling health literacy and health insurance literacy in a way that is appropriate for individuals they come in contact. The first one, of course, is as building on this idea of the framework, but the 3 major components of health insurance enrollment should be integrated into mutually supportive and iterative process. A lot of times we focused on outreach and enrollment first, or then sign up. Use has gotten a little bit of attention, but still, increasingly now, but hasn't been one of the main focuses. Yet, what we've learned is that oftentimes individuals, as in that quote that we heard, will touch all these at different points in their stages, not in sequential or linear fashion, and they'll go back and forth between all of them before they actually hit in each individual bucket in a way that is meaningful for them. One of the strategies practically that people have done this is to create opportunities for multiple touch points and to have convenient and consistent times for locations for assistance. As mentioned, individuals will come back multiple times. It takes several touches for them to, 4 at least oftentimes, for them to finally get to a point where they'll sign up and then think about using their health insurance, and to have opportunities and systemic processes in place, whether that's getting as simple as getting a contact information so that you can follow up, or having a consistent location at a public library that individuals can know in the community they can show up and go there. Those are important process and systematized opportunities to help increase the opportunity to have multiple mutually supportive and iterative approaches to all 3 of these buckets. Additionally, in-person assistance is absolutely essential and vital. One of the things that every organization probably told us is that in-person assistance for vulnerable populations is really the gold standard for helping individuals navigate across all these buckets. Lastly, in addition to this iterative process, not only to help individuals have multiple touch points, having a process to which groups can talk locally, but also interact with federal or state officials to share best practices, to iterate on their problems that they're seeing on the front lines, and then to share those across different organizations was also important to really develop this integrated and iterative approach. The second strategy, simple, is really to equip your assister. Assisters need to engage in conversations about the value of health insurance, the options available, how to use it, and what it will cost. And to dive a little bit more deeply on that, you have to plan for difficult conversations with vulnerable populations particularly, but really for anyone looking to access health insurance for the first time. Comprehensive conversations regarding the cost and affordability of health insurance must be constructed and incorporated to help ensure successful sign-up and retention. Well, what do we mean by that? Well, we learned really one of the key things is to equip your navigator with the right material for the right consumer at the right encounter. Each individual was at a different point in that process, but not all materials fit where they are in that readiness level. Diagnosing and filling knowledge gaps in order to help better approach and meet a consumer where they're at in that scale was really essential. For example, we learned for a lot of immigrant communities who have never accessed health insurance in the U.S. have no concept of what actually health insurance is. Forget talking about how do you use it, to forget talking about premiums, forget talking about deductibles. They're actually not even familiar with the concept of health insurance as a system. They come from countries where there may be universal care or there is no health insurance system at all. So understanding where the consumer is at to be able to meet them with the right material at the right time was really essential, and a strategy that was that when you took the time to think about really made a difference on the ground. And then another one is to really have to break down complex concepts with understandable analogies and anecdotes, and sharing those across as a group between different assister groups and those who are actually having those one-on-one conversations. Cost is an incredibly complicated and sensitive conversation, especially for those who, in their minds, think a premium is on the same level. Do I pay for a premium? Do I pay for food for my children? Do I pay for rent? And so that is a very complex, complicated, and sensitive topic, and being equipped and being willing to talk about those things in a way that was relatable was also essential for organizations on the ground. Number 3, meeting individuals where they are at. And so we learned that identifying data describing uninsured populations, perfectly by zip code, and make these data available to assisters was really one of the best strategies to target individuals and to find those who needed and to target resources. So geocoding data, we heard from a group in Florida who was working with Hispanic populations, that really being able to find culture, ethnicity, language, age, gender, literacy levels, income, all those things, inputs, help them target individuals in ways that they could help deploy their resources in a very focused way. 4th, build trust. Simple to say, hard to do, but intentionally design processes that will build trust with targeted populations and facilitate successful engagements with consumers. Some of the ways that individuals do this was to find trusted community sources that they identified in the local community, whether they themselves were working with them already. For an example, one group that was funding navigators and hoping to target homeless and runaway youth found it was much easier to leverage an existing relationship with a homeless and runaway youth shelter, and those youth were more willing to view those individuals they came in contact with less skepticism and already have a level of trust with them. And the other one is to think about physical locations or that were neutral or trusted sites. Going to barbershops, or going to faith-based places of worship, places that people are already going, and to try to reduce the stigma that might come from some of the terms that were being used around the Affordable Care Act or Obamacare. And so these were some process pieces that you could design, but really thinking about how and actively taking an engaged role, thinking about how do you build trust was one way to really reach and to build that interaction. And one thing I also wanted to mention was using unofficial trusted advisors. We learned in the immigrant population, oftentimes individuals who spoke English well and had connections to the community were viewed as trusted sources of knowledge in the community. And so using them as extensions into the community and spreading information that was accurate was also very, very important. Lastly, creating health literate materials. And so let's save this one for last because I know this goes without saying, but yet is incredibly difficult to do. And as we've seen today, there are many tools out there to help. However, individuals, we really need to think about how to facilitate development of culturally sensitive, well-translated, actionable health literate materials. Even some of the best efforts we found were interesting, that while there were many different translations out there available for, especially for Spanish populations, some of the fact that because there were so many translations led to confusion. You would go to 3 different websites with discussions around health insurance access, and yet 3 of them used 3 different definitions for premiums and deductibles, and as a result, people became confused, even though they were all written in Spanish for Spanish-speaking populations. And so how do you do that? Well, besides the fact that it's essential, pre-reviewing material, having committees, a diversity officer, some of these were on-the-ground strategies that individuals use, but really having action-oriented materials and checklists was instrumental for each person to move along that phase, helping people who are in the outreach phase understand, well, what is it that I need to actually do to be able to sign up? And then once the people have insurance, they have paid their first premium, what does they actually need to do and act upon in order to actually go see a provider to take care of my healthcare needs? So looking at 2015, there's estimated to be another 5 million new enrollees. Positive they're going to be even harder to reach, whether we've already had reached the low-hanging fruit, those that have already been interested in health insurance, the pent-up demand, and so we're going to have to stretch our hands and get into even harder to reach communities. And a lot of the projections are these are going to be people with even lower educational levels, higher percentage Spanish-speaking and other LEP populations, and geographically concentrated in the South. And so really have a hard task for us cut out in terms of reaching others and new populations to help give them information about accessing health insurance. And of course, retaining the 9 million that enrolled in 2014 as well. And really, as we think about post-enrollment opportunities, this is one of the big areas I hope to highlight. In addition to really thinking about how to be health literate in each of the buckets of health insurance enrollment broadly, but really is to start shifting the focus on, as individuals become newly enrolled in health insurance, how do we help navigate the demands and the complexities of how to use health insurance in this. And that's a lot of the work that the Roundtable is doing, and look forward to seeing more that you guys are doing as we go forward. So I'll stop there. I think we have more questions as a group, so thanks for the opportunity.